Hi, everybody. This is Carol from STS. This is the Adult Cardiac User Group call for January 20th, 2021. We're going to go ahead here and get started. On the line with me from STS, I have Jane Hahn, Leanne Jones, Emily Conrad, Eddie Dolan, and Melinda, who is our consultant, and she manages the FAQ mailbox. And then for my Q view, we have Jeanette, Jean, Joe, and Melanie. We're going to go ahead here and get started with a few STS updates and then updates for my QVIA. And then the pretty much for the user group calls is just a Q&A function. I have the Q&A box open. We don't have, I don't know if I have the raise hand function on yet. Hold on, let me see. Oh, I do have the raise hand function. If you need to speak, feel free to raise your hand. But if we could try to route everything through the Q&A so we are able to track the questions, that's actually really helpful for us if we need to do follow-up. If you have an open ticket number, please include that with your question. The next one is the important dates. Oh, I also wanted to point out that we have updated the slides for 2021, so I hope you like the new look. The important dates for adult cardiac, we have a user group call today. We have the monthly webinar on February 3rd at 2 p.m. Central Time. Harvest one is closing on February 12th, and we cannot extend the date. Opt-out will be on the 15th, and then we have the public reporting refresh for adult cardiac using Harvest one of 2020 data, which is through December 31st of 2019. That will be occurring in the early springtime. Just a quick update, some that we've covered on the last webinar. The January training manual has been posted. The Harvest 1 benchmarked report and Harvest 2-3 risk adjusted and benchmarked report are in beta testing with the beta users right now. Beta testing closes on this evening at 5 p.m. Eastern Time. IQVIA is working on the feedback that we received from the beta sites and hopes to have that implemented as soon as possible. They're reviewing it and doing some investigation on a few of the issues that were noted. Nothing too major, but some of the calculations that they're working through to make sure that they have, make sure their programming is up to speed. And then we we'll have more information tomorrow on the release of that, but it is coming very soon and it's right around the corner. STS will notify folks when those reports are available to the entire community. Harvest 2021 schedule is posted on the website. And again, we cannot extend the Harvest 1 deadline, which is February 12th. So it's very important. I know some folks are getting told to give vaccinations, or you're having influx of COVID cases at your site. It's really important to work with your administration to let them know that we cannot extend the harvest due to some reporting deadlines that we have that occur quickly following the harvest close. So we need to make sure we can get your data in, cleaned up, and submitted for that harvest close date and for analysis at DCRI on February 12th. Public reporting is again expected to be updated in mid-March around the springtime in 2021. Well, we reviewed this last time, but just to for those who maybe were not able to be on that call, starting with January 1st, cases, we're asking that you use the temp YN2 field to capture this Edwards PhysioFlex angioplasty ring, which was FDA approved. For implant model number, you will choose, I believe it's 777, which is other FDA approved. You can input the implant size, and then you'll need to use the unique device identifier. There will be a field on this form that's already posted. The updated DCF is posted that has this temp YN2 available, and you would just answer yes if they did an implant, a mitral valve implant, and it was the Edwards PhysioFlex angioplasty ring. And then I'm going to hand it over now to Joe Brower for the IQVIA updates. Joe?
Great, thank you very much. Good afternoon, everyone. We'll start off with some updates that went into effect last weekend on January 16th. starting with some enhancements for direct data entry users, STS 4931. The algorithm for calculating the initial and total ventilation hours for the version 4.20.2 form has been updated. So you should see that in effect already as of this past weekend. And STS 5209, a case list update for direct data entry. There is now a hospital NPI column added to the case grid, which you can use to filter your case list by. And so that column is an optional setting, and it will not be displayed by default, but you can add that using the settings in the upper right corner of the patient grid. A couple of issues in regard to the participant dashboard report. STS 4564, the other non-card other Thor and the other non-card other VASC items were not showing up. Rather, they were showing up as missing when no was selected on the form. And so a fix has gone through, so that should be displayed correctly now. And then STS 5028, the intra-op blood products were not showing any results on the dashboard, but that should now be resolved. And so those items should now be displayed. All right, next slide. The items listed on this page are set to be added in a release this coming weekend on January 23rd, and a update will be posted to the notifications section for both this and the one from last weekend. So if you want to review those items, they are available in your notifications. For this weekend's update, starting with STS 5506 in regard to the data quality report, we are adding some additional validation checks and edits for the 4.20.2 version. And an updated list will be posted to the library for you after the fix goes live. In regard to the MIPS performance measures report, SCS 4732, all measures are being updated to exclude patients who are identified as still in hospital for both versions 2.9 and 4.2. And then for the patient-centered risk assessment measure, STS 7, exception logic is being added to update to exclude emergent or emergent salvage status patients. For the harvest summary report, STS 3824, that report was displaying outstanding errors for the prep TR variable, and that will be resolved in this release this coming weekend. And then another item in regard to the participant dashboard, STS 5386, there was a discrepancy in the post-op event calculation on the dashboard, and that has been resolved. The total number of cases that were answered for deep sternal infection, mediastinitis, was greater than the number of total cases that were answered either yes, both, or yes, infectious for surgical site infection within 30 days. And so that calculation has been corrected. And so those numbers should display correctly after this weekend.
Great.
All right. And so for this page, the ACS, the risk adjusted dashboard, the star rating, that is displayed. If you look at the little picture on the right side of the slide, for some of you who are using Internet Explorer version 11, or excuse me, greater than version 11, you'll encounter an issue where there's kind of an ellipsis displayed after the stars. And that is because Internet Explorer is not a supported browser. And so if you're using Internet Explorer, you are going to be seeing that issue. So to get around that, just use a different browser. You can use Chrome, Edge, or Firefox. Any of those should display those results correctly. All right, finally, we have one last slide here for some issues that are currently under review. We are working on an issue that has been reported for the non-analyzed participant dashboard, where the operative mortality variable in calculations are not showing how you'd expect them to display. So we are working to make some updates and improvements for that calculation so that the operative mortality variable in that report is a bit more useful to you and a bit more in line with what you would expect to be seeing for that.
Very good. Thank you, Joe.
That's it. Thank you.
Thank you. Okay, and then the IQVIA support plan, nothing's changed. Reach out to IQVIA. We have calls with DCRI and IQVIA, kind of touch bases once or twice or sometimes more a week. And we heard from DCRI that they're seeing quite, for sites who have questions about their risk-adjusted reports or why they are not receiving a star rating or why they received a certain star rating, that sites are reaching out both to DCRI and IQVIA. All questions should first start at IQVIA. IQVIA is able to answer those questions for you. So if you have a question related to that, please reach out to IQVIA instead of DCRI. We will route your questions to DCRI if we're unable to answer those either through IQVIA or the STS support. So please reach out to the STS tech support at IQVIA or the phone number first, and then it'll get routed appropriately, just to help make sure that we get you the answers as quickly as possible. DCRI doesn't have that readily available as they will at IQVIA. And then we have the additional resources. The STS tech support at IQVIA is the email if you have questions about your uploader or any of the reports. The National Database Feedback Form is available as well. And then my email address if you need to reach out to me. And now we're going to go to the open discussion Q&A, and we want to hear from you. So feel free to answer questions. And I'm going to go first to Nancy Satu, who has a question about what years do we need for MPI anesthesia hospital to enter the MPI for anesthesia if you participate in the anesthesia section. So Nancy, the MPI for the anesthesia section applies to the years that you've participated in the anesthesia section. I sent you an email earlier today. If you have additional questions, please respond and I can check further into that for you. Next question. I'm going to go back to the timeline slide here because I think there was a few questions on the timeline slide.
Sorry, Carol, this is Jeanette, just on the IQVIA side. So I just wanted to confirm that the history of your anesthesia enrollment or non-enrollment hasn't been shared with us. So those validations are actually going to be applicable for all of the submissions that occur to the data warehouse at this time.
Okay, thank you, Jeanette. How soon after submitting data are you able to see it in the ACSD participant dashboard to view reports? And I know it's near real time, but you feel free to please.
Yeah, this is Jeanette. So the participant dashboard is going to be refreshed after you do an upload. So once the card appears in the uploader interface, it's going to generally take between 5 and 30 minutes for the data to show up in the participant dashboard. It sort of just depends on how big your submission file was. We've got to run through all those calculations and get that updated so it's showing in there. And it also sort of depends on how much activity there is in the system at the time. There's kind of a variety of factors, but it should be there within less than 30 minutes.
Thank you, Jeanette. Next question: are patients with COVID positive patients in the denominator for reports? So on the IQVIA side, those patients are not being excluded in the raw data. So in your various uploader and harvest summary reports, they are not being excluded. However, when that data goes over to analysis at DCRI, they are excluding those patients from the denominator of the reports, and they will be reported out separately on the IQVIA benchmarked reports. What dates are included in the public reporting? So public reporting, which is expected to be refreshed earlier this spring, will include the cabbage composite is a 12-month composite. So that will be January 1st, 2019 through January 31st, 2019. The valve composites and valve plus cabbage composites are based on 36 months of data. So that would be January 1st, 2017 through December 31st of 2019. I tried to get my post-op pneumonia rates for ICAB patients. It doesn't appear that complication data is available. Am I missing it? No. So Deborah, that information will become available with the benchmarked reports which are currently finishing up beta testing and anticipated to be released in the very near future. We will let sites know when those are released. Beth has a question regarding MIPS, and this, Beth, all MIPS questions need to be submitted to Donna McDonald, and I'll have Leanne put her email in the chat box for you.
And Carol, can I respond? It's Melanie. I
Yeah,
actually
sure.
spoke to Beth yesterday. So Beth, I did send you a follow-up email in regards to our discussion for yesterday. So I'll send another update later on this afternoon, but you should have received that maybe about a couple minutes, 10 minutes ago.
Thank you, Melanie. Next question is, I came on the call a few minutes late. Was there an update on the next harvest deadline? So we will not be, the harvest deadline is set for Friday, February 12th at 11:59 p.m. Eastern time. We cannot extend it related to other deadlines that are pending the analysis of this data. So we will not be able to extend it past February 12th. The opt-out is February 15th. Can you show, oh, so I'm showing the deadline screen. I think this is what you want, Elizabeth. Let me know if it's something different. Is the new temp field only if valve placed in mitral position, or does this include all valve positions? So it is just for the temp YN2 field is just for the mitral position. It will show up blank on your other cases because it's a temporary field that doesn't have any parent-child parents related to it. So it will show up blank. Unfortunately, you can just ignore it on the missing variable report, but it is intended to be filled out for all mitral cases that have implants. When will we be able to see our current contact forms on IQVIA? And I think that has to do with the CRM integration. And I don't know if I'm not the one to give update on that. If anybody is. Okay, I think it's coming soon. We're still working on the CRM integration, which is our participant management system. We're still working on the integration between CRM and between STS and IQVIA. So it should be soon. However, if you need to get that list, you can email us at stsdb.org. stsdb@sts.org. Oh, Jane, did you want to take that question, or did I get it okay?
You were perfect, Carol. Thank you.
Okay, great. And we'll put that email in the chat box for issue Lee. For the adjusted report, it doesn't let you filter by physician. Is there a way to filter data by surgeon? No, we do not have NPI filtering available at this time on the reports. If your surgeons are interested in obtaining a surgeon level composite measure, you could also reach out to stsdb@sts.org. Leanne just put that email in the address, and there's a consent form that they would need to fill out to be able to have access to their surgeon level composite report. Can you give me more info on COVID-19 patients being excluded from star rating? Is that any patient tested time pre and post-op COVID positive test, any inclusion or exclusion? So it's any patient who's tested positive for COVID. We do not have a time exclusion currently applied to those patients. So any of the yeses would be excluded. And I can, oh, I wasn't in full screen mode. Sorry about that, everybody. I can show you that here. Oopsie. I bet everybody's getting really good at navigating the website now, watching me do it so many times. So it's under registries and research, adult cardiac surgery, and then I'm just going to the DCF to show you those COVID fields where it's being excluded. It's any of these yeses, harvest code 11 through 14, that are being excluded from analysis at this time. The STS Surgeon Leadership and our research center are doing additional analyses on these patients, and further recommendations will be data-driven regarding exclusion from subsequent harvests. At this time, it's NES. Is there any documentation on the STS website regarding suggested fields for internal auditing? We don't have anything specifically posted. That's a great question, Heidi. We don't have anything specifically posted for auditing. However, I can tell you what you would want to focus on are things that impact your outcomes. So your risk model variables, the endpoints that we use in the risk adjustment, in the risk adjusted measures and the NQF measures. So those are probably the most important. Again, that would be your risk adjusted variables, and your post-operative complications, things that are used in the risk adjusted endpoints. And also you would want to check probably what's used in determining procedure identification as well. I'm sorry I missed this, but I am only able to see a report for 2019. Is there a newer risk adjusted report available? So that report should be coming very soon. Beta tested is just finishing up on that today. And IQVIA is working on some of the feedback that was received, and we'll have a better timeline later this week as to when that will be released. Are there how-to videos on how to view the STS harvest reports? So this is, Vanessa, I think you're asking if there's educational videos on how to use the risk adjusted and benchmarked reports that come out. And I'm not sure if they're posted yet. Melanie, would we be expecting to have these, or are we just using the webinar?
Jeanette, we've got PowerPoint overviews posted. We got some feedback from the user community that the videos are a little bit hard for you all to pull up and just refer to like a section quickly. So right now in the system, we do have the overview, the PowerPoint overviews posted, which will allow you to sort of see all the sections in there and then jump to the individual area in order to maybe get a quick answer to your question. And that's posted in the resource library in the system currently. There have also been some walkthroughs of the reports in these sessions that are recorded and available for your reference if needed.
Great, thank you, Jeanette. And again, that's on the IQVIA platform in the resource section. Early in the pandemic, there were limiting testing sites and limited supplies. Therefore, patients who might have had COVID were unable to be tested. Later, antibody testing revealed the patients actually had COVID at that time. Since STS only accepts PCR tests for COVID, how is STS resolving the equity between sites for timing of the pandemic surges and testing inconsistencies? So we are still sticking with the positive PCR tested is needed for exclusion of those patients for analysis. My chief surgeon told us that the cabbage composite was going to a rolling 3-year period, just like valves. When is this happening? I'm not sure that that is correct. It will be going to a 3-year or a 36-month time frame. We don't have a time yet. It will be happening in 2021, and we will let sites know when that is going into effect. Can we review the first 3 minutes of the announcement? So I'll just put this up on the screen. You have the dates here that are coming. That's been up there for a while. And then the harvest reports are the harvest one benchmarked and harvest 2, 3 risk adjusted and benchmarked are just finishing beta testing today. IQVIA has received feedback from the beta testers who have spent endless hours reviewing it, and we anticipate to have those reports out very soon, as when IQVIA goes through and makes some adjustments according to the beta testing feedback. We anticipate those reports hopefully next week sometime, but we'll inform folks when we do have those posted. Can you please actually show the public reporting information you talked about, please? I'm not sure what you're looking for, Donna, but the public reporting information is available on the STS website. So if you go to registries, STS public reporting, you can find more information here on public reporting and what goes into each of those. I'm not sure if I answered your question, but please provide some more detail if I totally missed it. I am unable to hear this presentation and the phone number provided says I'm dialing incorrectly. I have just a question. When do you expect any anesthesia reports to be coming? So Leanne, would you mind typing in the answer that they will be released with the benchmarked reports that are hopefully coming in the very near future?
Yes, ma'am.
Thank you. If a surgeon would like to discuss a metric or data element with the STS surgeon, how can that happen? So first I would say to submit that question either to me or to Melinda at the STS FAQ mailbox. Feel free to submit it to me and I can have one of our ACSD surgeon leadership members reach out to your surgeon to discuss that data element. My email, I'll put it in the email in the chat box for you. Melinda, are you here? Are you unmuted? Because I think we're going to have a couple questions here coming.
I'm here.
If question for VAD implant is no, should VAD explant be answered, or should that question gray out? Oh, or should that question gray out as unavailable? Well, no, because I still think you can have an explant even if you don't have an implant.
Yeah, it doesn't gray out, and I've just been telling people to answer no.
Yeah,
If
that's
it's not an
how.
explant.
So let me pull that up real quick on the DCF.
I've had quite a few questions about that come through the mailbox.
Is it an issue with the form, or is it just that?
I think it's just a child of the VAD, and so it has to be answered. That's my general take on it.
Yep, that's true. So you can always have an explant without having an implant. So the explants are, you could have an initial explant and never have another implant, or you can just have an explant for whatever reason. So that there's no parent field here besides that a VAD procedure was performed. So if there is not a mitral physio ring implanted, do we code no or leave blank? If there was a mitral procedure performed and there was an implant, then you would answer temp YN2. If that implant was mitral physio ring, you would answer that as a yes. If there was not, if the device that was implanted into the patient was not the physio ring, you would answer no. Otherwise, you will leave it blank. Melinda, for patients readmitted with COVID, what reasons are we selecting?
Well, you know what I've been telling people, it depends on what their presentation is with the COVID.
Yeah, I agree with that.
And with that, we have to look at it on an individual basis and what the primary problem that was treated and care that was provided. So
Yeah, it would be driven by their symptoms, correct?
correct.
Okay. Is there a way when running a report to also have the MRN populate on the exported report? IQVIA, that one's for you.
This is Jeanette. The medical record number, or MRN, hasn't been raised as a priority field for all the participants. So this is a very interesting suggestion. We'll need to take this back and discuss it with the STS team.
Okay, thank you. And I think, okay, thank you. Next question, when can we expect to see our analyzed report for second quarter 2020? So that report, as I've stated, that report is finishing up beta testing today, and hopefully we'll have it out in the very near future. IQVIA is working on the feedback that they've received from the beta testers. Are the surgeon-specific report links posted in STS or just sent to the surgeon's email? So do you all want to take this one? My understanding is that it's on the surgeon dashboard when they log in.
Yes, Carol, you've got it. So when the surgeons log into the system, they can see their own NPI report.
Great, thank you. So it's in the IQVIA platform for the surgeon's login. If the patient has no history of lung disease and FEV1 is normal, do we still use DLCO to determine lung disease? So this is a great question because this is actually one that we have recently provided clarification for in the training manual, because there are some patients who have very poor DLCOs, but their FEV1s are normal. So let me pull this up because I think we did Dr. D'Agostino and Melinda worked very hard to make sure that we had this clear. And Melinda, do you happen to know? I don't want to do all this.
It's sequence 405.
Thank you.
It's imprinted on my brain.
Oh, it was a little painful. So this is the training manual sequence 405. This update was placed in November following AQO and some feedback that happened around AQO time. Dr. D'Agostino worked with some pulmonologists at Leahy to come up with this to help us code this better. So what it says is that the DLCO can be used to determine the severity of lung disease. The lowest predicted of either of the simple DLCO or DLCO-VA uncorrected should be captured. And then further down it says code the most severe category. If there is a discordance between FEV1, DLCO, the ABGs, or the inhaler criteria, then you would follow this hierarchy. So if the FEV1 is 60%, which that's a norm, that's considered mild. The DLCO is 45% and the ABG-OPO2 is 50%. You would code this as severe. You're basing that off of the room air ABG, right?
Correct.
And we have the DLCO listed up here. The criteria listed up here: mild is greater than 60, DLCO moderate is 40 to 60, and severe is less than 40% of the predicted. So another example would be the FEV1 is 45, which is considered severe. You have a DLCO of 40, which is considered moderate. You're going to code this as severe because you're going to code the most severe of these two, which is the FEV1 of 45%.
Right. I think the only thing I want to mention is for the DCLO, the mild criteria there, it's greater than 60%, but it's lower than the lower limit of your normal. So you have to look at your limits when you are looking to see if the patient may have a mild lung disease based on the DLCO. So I just wanted to point that out so people understand that you do have to look at your lower limits.
Yeah, that's great because this next sentence here, I think also covers that, but that additional, so it says, for example, DLCO is 72% and the normal value, this would be facility, is this facility driven, Melinda?
Yes.
What the normal values are? Okay. So if the normal value at your facility is considered 80 to 120%, then for your facility, this 72% would be considered mild. Great question, Marina. Can you please give the dates of the IQVIA dashboard walkthrough so I can reassess them? I think we've been doing walkthroughs on all of the monthly webinars. So you probably want to start with January's webinar because I think Rhonda did a walkthrough on that one, and then December's. There's also things posted in the IQVIA resource section on the IQVIA platform to help with those. Just a suggestion, Cisco WebEx has a closed caption function that transcribes the audio of the meeting that could possibly help with searching through past webinars. Okay, thank you. The VAD explant question actually is open and you have to answer it twice. don't know why you would have to answer it twice. Are you saying you have to answer maybe the parent to the second one?
I'm not sure what she's,
Yeah. We can check into that one, Beth. Thank you. What is the advantage or reason to sign up for the anesthesia component in addition to the ACSD? The anesthesia component gives you more specific data related to the anesthesia care of that patient from OR start to usually it's 1 day, 24 hours post OR. So your anesthesiologist can use that to monitor the intraoperative care of that patient and how they're doing post-operatively. I'd be happy to answer more questions, Julia, and we can go through the anesthesia section in more detail if you have specific questions. My email is in the chat box there. So left atrial appendage, and I think, Melinda, we're still following up on this one with the surgeons regarding the obliteration versus the amputation.
we had to cancel our last meeting with them. So that's on the queue for the next meeting.
Okay. Could you show your slide about the new mitral valve field? Yep, okay. Got lots of questions today. If you leave it blank in Navion, it arrows out the temp field. It errors out.
That's probably vendor. I would suspect that would be vendor specific. And if it's making you answer, just answer it no, Katie, if you're not using that valve.
Okay. Is mortality all cause if we have a patient that expired on day 27 because an oxygen tank blew up? Does that count against the same as car accidents and death? Yeah, unfortunately it is all cause mortality. So regardless of the cause, you would still count that patient as a mortality. Please add the MRN. The surgeons cannot access any other number to find the patient's reference. Okay, we'll take that back, Heather, with IQ, like Jeanette said, and review that with IQVIA. Okay, according to the training manual, if a patient discharges to hospice, we are supposed to count them as an operative mortality. Is this true regardless date of death? Yes, it's true. No matter when that patient expires, that patient is counted as an operative mortality. What if the patient discharges home, then gets hospice involved post-discharge? Should they code that patient as a mortality? No, we're looking for patients who are discharged on hospice for that field. Reading the, no problem, Marino. It's that the DLCO questions in the FEV1 for CLD are really difficult. So anytime you have a question, the training manual says that it can be used, not that it should be used. So am I clear that we should use it regardless? Yes. For Melinda, if pre-CPB anesthesia does not notate AV regurg, and upon post-CPB, they note prior to leaving the OR, anesthesia notes LV function, but no valve assessment, we are not to resort to pre-op echo, correct? My understanding is that we should code not documented. Am I understanding this? Yeah, that we're looking at the intraoperative fields.
Yeah, she said that pre-bypass, they didn't notate AV regurg. So that would be not documented. And upon post, they don't document it either. So I'm just saying, yeah, both would be not documented. If I understand your question, Heidi, that's what I think.
Heidi has her hand raised for, I think she wants to clarify.
Okay.
Hello?
Yep. Hi, Heidi.
Hi. So on our intra-op TEs, our anesthesiologists will put a pre-CPB section and then a post-CPB section. And my pre-section, it says LV, global hypokinesis, RV function normal, moderate MR, central jet, P2, P3. My post says blah, 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 blah. Remainder of exam is unchanged. So neither one documents my aortic regurg within the intra-op TEE. My understanding is that we are not to go to our preoperative TEEs and utilize those values, right? Once you're in the OR, you're in the OR. You can't go back to your preoperative TEEs or echoes, correct?
Oh, correct. Yeah. I mean,
Thank you.
2565 is for an intra-op TE
Correct.
post-procedure. So
Right.
it's the
You
one
can't-
done intra-op.
Right. So you can't go back to your preoperative ones and try and utilize those. I just want a clarification on that, right?
Right.
No,
Right.
looking at the
Thank you.
procedure, how, yeah, you're welcome.
Perfect. Thanks.
Sequence 405 typo DLCO, not DCLO. Thanks, Emma.
Thanks, Emma, for my dyslexia. You're pointing my dyslexia out.
Let's see, if we have a patient that was readmitted due to COVID-19, what readmit reason should we select? So again, it's what the patient, the symptoms that the patient came in with, or whatever the diagnosis was outside of COVID-19. If they're coming in with pneumonia, then you would code pneumonia. Is an MVR plus a tricuspid valve repair equal to isolated mitral valve? Yes, as long as that mitral valve replacement was done as a planned procedure or a due to unexpected disease or anatomy. Then it will stay in the isolated MVR category. Can I designate AVR, MVR, TVR to AVR, MVR category? Yeah, I think that stays in the double valve category. Let's look at that real quick. So I'm going to the PROC ID chart and I'm going to look for the double valve. I think it's PROC ID 8. So we start with 1 through 4. Oh, I'm sorry, it's PROC ID 6. So the AVR, MVR, and you're asking if that patient has an AVR, MVR with a tricuspid valve repair, where that goes. So I will look for tricuspid valve procedures in the left-hand column, and it says all tricuspid valve repairs are allowed. So you keep that patient would stay in the AVR, MVR category, assuming that the AVR and MVR were done either as planned or unsuspected due to disease or anatomy. It will stay in the AVR, MVR category. You're welcome, Marina. Would you please clarify the change to only participant level public reporting in 2021? Does this mean star ratings based on MPI numbers will no longer be reported and only star ratings based on PID numbers will be reported? I'm going to ask Jane Hahn if she wanted to take this one, if she's available, because I'm not really sure.
Yes, that is correct. Public reporting will be at the PID level only. Although we will be listing hospital names and their city state on that PID page so that the patient population, the public knows where to go. So that additional detail will be provided.
Thank you, Jane. Can you please answer the hospice and mortality again? Any patient who is discharged to hospice is to be counted as an operative mortality, regardless of when that patient dies. If a patient is discharged to acute care hospital, so discharged, by discharged you mean transferred to another acute care hospital, do we include all blood products given at the other hospital in our STS registry? Yes, any patient that is transferred to another acute care hospital following a procedure at your hospital, you're to collect the post-operative sections until that patient is discharged from acute care, no matter if they're at your hospital or subsequent hospitals. So you should collect all blood products given at the other hospital as well. And then I see we have a hand raised, Cindy, and you might have to unmute yourself, Cindy. You can go ahead and talk if you have a question. Okay, not hearing you, so. Okay, another question. So Cindy, if you have a question, oh, there you, never mind, your hand went down. Okay, another question is an AVR plus aorta root considered isolated AVR? No.
No.
these procedures, the AVR with any aorta is not considered an AVR procedure. We don't have a risk model for aorta procedures at this time. The data from 2.9 is being looked at, and they are the aorta task force is working with the quality metrics task force at STS to build a risk model. And they've started that procedure. They started that about a month ago. So we should see some risk models coming out probably within the next year for aorta. But at this time, any procedure that is combined with an aorta procedure goes into the other category. What if the patient gets a referral to hospice prior to discharge, but isn't initiated until after discharge? Okay. If the intent is for that patient to go to, I think we would probably want to review this one with the surgeon leadership. If their discharge status is discharged to inpatient or discharged to outpatient and they're going home.
Or discharged to home hospice.
Yeah, home hospice is the same as hospice.
Right.
I would probably want, if Courtney, if you have a specific patient that you want to ask about, we'd be happy to hear more from you. But I think that these are kind of what ifs. So really it's difficult to answer that question. Patient discharged alive dies after discharge greater than 30 days from OR, traveling to ED, codes en route, unsuccessful resuscitation, expires in the ED, but was never admitted. What do I code as the location? We've had this one before, Melinda. How have we answered that?
It's out of hospital. It's because ERs are outpatient areas. So
yeah, these patients don't count as readmitted, right? Because they were not,
right.
not readmitted yet. Okay.
And I think
Mind
that
you,
the death location is out of hospital, or I can't remember the exact choices we have, but it's not in the hospital unless these patients are inpatients, which usually they're not. If they
yeah,
die in the ER.
This one wouldn't count as an operative mortality either, because it's greater than 30 days from the procedure date, and they were not in the hospital. So this would not count it as an operative mortality either.
Correct.
Okay. I recall from previous webinars that we are not to code preoperative echo valve assessments with no regurgitation documentation by opening up parent field regurgitation and code the child field not documented. I'm not sure what's going on there.
I know what Kevin's talking about. So in all the pre-op fields, it's just a yes or no, whether you have regurgitation. And if there's no mention, then the answer is no, you don't have it. Don't open up the field and answer not documented. But I don't know what he's asking about the intra-op, because I think it's not the same. It's not the same parent-child setup. So intra-op, if I'm not mistaken, you can answer not documented. It's a choice. And it's not a parent-child like it is pre-op. I hope that answers your question, Kevin.
Yeah, thanks, Melinda. Patty's asking about the aorta risk model, what categories will be included, and that's what it probably will not be dissection. They're looking right now at aneurysms, and they're looking at from root to zone 3 right now, and it will be kind of they're really difficult to build because of the way there's not just one type of procedure. So right now, yes, it is just planned. They're looking at just aneurysms, and they're looking at the zones that I just said, zone 0 through zone 3. But they're really in just the very beginning planning stages of this. So the week before Christmas, we went through and pulled out variables that they were going to have the statisticians pull out at DCRI to do a little bit more investigating to look at weights and impact and things like that on various risk factors and procedural factors for these patients. So it's really just in the beginning stages, but it is on its way. So is it other?
I don't know what Elizabeth's referring to.
So sorry, I'm still focused on these procedures. That's okay. The procedure reference was AVR, MVR, TV repair. You answered it. It's a double valve. Does it hold true for TV replacement? So you'll find when you look at the PROC ID chart, we're still going to look at AVR, MVR for PROC ID 6, and we'll go down to the tricuspid valve section here. It says all tricuspid repairs are allowed. Tricuspid replacements or surgical prosthetic valve interventions, not explanted valves or valvectomies, are only allowed if the tricuspid procedure was unplanned due to surgical complication. So if you had a patient that was a planned aortic and mitral valve replacement, they take that patient into surgery, and for some reason, something happens during the surgery that causes the surgeon to have to do a tricuspid valve replacement. It would be considered a surgical complication. Then it would stay in the AVR, MVR category. If it was a planned tricuspid valve replacement, in addition to the AVR, MVR, it would move it into the other category. I just want to clarify Melinda's answer to the previous question regarding intra-op TEE. If the result of the intra-op TEE post-bypass states remaining valves unchanged, then we can capture the valve assessment stated in the intra-op TEE prior to placement of CPB. We cannot utilize the pre-op TEE results for post-procedure TEE. The answer given wasn't that clear to me, perhaps just misunderstanding. No, you have it correct, Heidi.
So I think the question before was there was no documentation in the pre and there was no documentation in the post. So we just documented it as not documented. This, in my mind, is a different question because this is a pre-op, this is an intra-op TEE done pre that actually assessed the valves and in the post said all the valves are the same, nothing has changed. So then, yes, you can use the pre-results that were addressed, the pre-intra-op, okay, results that were addressed in the post.
Oh, it's not Heidi's question. It's not Heidi's question. Somebody else's
Heidi? I didn't see that was Heidi.
Yeah. Sorry, Heidi. Heidi's got it. It was somebody else asking this question, Melinda.
Oh, okay.
Okay. Welcome, Patty. And Melinda, Kevin says, thank you. That made sense. And then I logged in late due to some internal internet issues. Did you show a slide with the known IQVIA issues and fixed IQVIA issues? Yep. I'll scroll through the slides. We have a couple minutes here, so I'll just let them up on the screen there. Okay, and then sorry for location. There's no choice for out of hospital, just other, referring to my question, patient expired in ED. So it would be the, oh, sorry, Elizabeth. Yeah, so it would be the other option. My allergies are kind of bad. Sorry, everybody, for sounding congested. So I'm just going to scroll. I'll show you. We'll look at the choices together, Elizabeth, so we can all see what we're talking about here. So you're looking for location of death, post-discharge death location. And for this one, you would just code it as other. Would you code it as other, Melinda, or would you code it as home?
I think it's coded as other. I think that's actually in the training manual.
Let's see.
Because it wouldn't be home because they were in the ED.
Yeah, I remember talking about this.
That's discharge location. Let's go to death.
Oh, here it is. Yeah. So this was the note down here. As a patient died within 30 days of discharge. Yep. This is a little bit different than yours, but cardiac arrest is documented in the ED, code other for this death location, since technically the death was outside of the hospital. So for that patient, Elizabeth, you would code other, as Melinda said. Okay, I'm waiting, Julia, for you to send in your last question. And then Donna says DC location would be other. Yep, thank you, Donna, for the DC location for other. And, oh, somebody wanted me to show these. So these were the, oh, MVR plus maze is not an isolated MVR. No, actually it is, Julia. Okay. April 1st, we did a really great webinar on the PROC ID chart. I highly recommend reviewing that webinar. It went through the PROC ID in a very detailed way, going through like line by line. But let me show you. So we're looking at mitral valve replacement, which is PROC ID 3. And because you're going into the cavity and you're performing this maze procedure, you're already in kind of that same spot. So both epicardial and intracardiac maze procedures performed along with the mitral valve replacement keep it in the mitral valve category. So we're looking here at, this is row 3 here. And it's not used in this calculation, which means that we don't even look at this. So we don't even look at these fields to say if it should be removed. It's automatically included unless there's something here that says what part of this would be an exclusion or inclusion criteria. So the AFib lesion location keeps it within the mitral valve replacement category. If we looked at, the first one is, we'll look at CABG. If they did a CABG and they did an AFib lesion location and they had it marked as either epicardial, none, or missing, this would keep it in the category. However, the intracardiac AFib lesion location is not listed here. So that means that it would, would move it out into the other category. When it's not used in the calculation, it just means that it doesn't matter what the answer is. It doesn't have any impact on if it stays in or stays out as an isolated procedure. So for your case, the mitral valve replacement plus maze, it is considered an isolated mitral valve replacement because we don't look at this to determine the procedure identification. Does not matter what's answered here for mitral valves. And you're welcome. Oh, we had a lot of questions today. Thanks, Melinda. And thank you, Jeanette and Melanie. Anything else?
Carol.
Yeah, that was a good one. Oh, I'm still going through these issues here, slowing these slides real quick. So I don't know if you have any questions, but I'm just gonna keep scrolling through. So again,
Carol, these are also posted. Sorry to cut you.
Oh,
these are also
okay.
posted under the notification section within
Oh.
the platform.
Okay, so these are already posted, and if you need to refer to them, you can go over to the IQVIA platform and find them there. Thanks, Melanie.
You're welcome.
Who was that? Who was asking that question? Okay. Oh, I think it was Victoria. So Victoria, just go ahead and log into IQVIA and you'll be able to find them there as well. And any other questions from folks? Okay. All right. Thanks, Oh, you're welcome, Victoria. You're welcome, Angela. You're welcome, Cyrus. Anybody else have any questions? If not, we'll call it a day. Thanks everybody for joining. Thank you, Melinda and the IQVIA team and my STS colleagues. I really appreciate your help on these webinars, and thank you everybody for joining. I hope you all have a great day. Stay healthy and safe. Thank you.